So welcome everybody to the Northern Virginia Family Practice Town Hall. Tonight we have a really fun guest for you. Anastasia Palaia is a doctor of physical therapy and an expert in the pelvic floor. She's treated all ranges of conditions, which we'll let her discuss with you. I'm co-hosting tonight with Dr. Beth Cilenti. Beth has been a physician in the area for, I think, 5 or 6 years. Both of us used to work at Unity Healthcare. Beth came recently from being a professor at Georgetown. She's a physician in internal medicine and pediatrics, and she's co-hosting with me tonight. And I will invite you to put questions into the chat as we go, and Dr. Cilenti will be helping to field those questions and pass them through to Dr. Palaia.
Great, thank you. And so nice to meet many of you who I see a few familiar names and look forward to meeting many more of you. I just wanted to take a moment to introduce Dr. Palaia and tell you a little bit about her expertise and why she's speaking to us tonight. So she's a doctor of physical therapy who specializes in holistic care of active people. She received her doctorate from Shenandoah University and then completed a residency at the Institute of Physical Art and learned hands-on techniques to help better effectively treat pain and enhance performance. So she's a certified functional manual therapist and is also trained in something called visceral mobilization and really uses a whole body approach to evaluate and treat her patients. She has worked extensively as a pelvic floor therapist and as a pregnancy and postpartum corrective exercise specialist, and has worked extensively with professional, amateur athletes, dancers, runners, and athletes of all levels, and is really passionate about helping people excel in the gym and eliminate barriers to their athletic pursuits. We're really excited to hear about her expertise in pelvic floor today. And with that, I will turn it over to her and look forward to hearing and learning more about this myself. So thank you so much, Dr. Palaia.
Thank you. Thank you, Dr. Cilenti and Dr. Beauvais and NVFP for just having me here. Like I said, I am always really excited to nerd out about the pelvic floor and share information about the pelvic floor. My presentation today is a little bit more geared towards women who have carried or given birth to children, but it's applicable to anybody who has a pelvic floor. But you'll hear me talking a little bit more about people who have given birth to children. I think that the first step that I'd like to take here is just talk a little bit about the pelvic floor itself and what pelvic floor disorders actually are, especially because some of the symptoms are a little more subtle and don't always occur to us, especially since pelvic floor is a little bit new, a little bit of a new topic and sort of becoming a little bit greater in the public awareness. So first, let's get to know the problem. There are 3 primary and frequently seen pelvic floor disorders, especially in people who have been pregnant or given birth to a child. The first pelvic floor disorder is called incontinence, and there are many different types of incontinence, but generally it means the involuntary loss of urine, stools, or flatulence. The next most common pelvic floor disorder is pelvic pain. So pelvic pain can be pain in the pelvic viscera, the pelvic cavity, or the pelvic floor muscle itself. Another common pelvic floor disorder is pelvic organ prolapse, and that just means the descent of pelvic floor organs or tissues towards the opening of the vagina or the anus. So if you were to type your symptoms in Google, you may have seen some of these names and they seem a little bit intimidating, but what we're about to go through next is a list of symptoms that are often seen in people who have pelvic floor disorders. So these symptoms can certainly range in severity. They can be very subtle with some of the more behavioral symptoms, or they can be really dramatic, like extreme pelvic pain or spasm or full loss of urine or stools. We often also see a continuum of progressiveness of these issues. Certainly some people are like that frog in the pot of boiling water. They just the incontinence starts really low or the pain isn't really so severe, and slowly over the lifetime it becomes worse. Or we can see more sudden changes in people, such as just after childbirth or just after menopause. Some common bladder symptoms, we're pretty familiar with things like leakage, with coughing, sneezing, or laughing, but some of the less common symptoms are difficulty voiding, like not being able to start or stop your stream. Maybe you go to the bathroom, but when you stand up, there's some dribbling. That's another sign you may have a pelvic floor dysfunction. If you can't make it to the toilet in time, or if you have a constant urge to pee, you've just urinated 15 minutes ago or even 10 minutes ago, but you now have the urge to go again, that could be a sign of pelvic floor dysfunction. Waking in the night more than twice, especially if you are a younger adult, that is a sign of pelvic floor dysfunction. Or more sneakily, these kind of more behavioral signs of pelvic floor dysfunction, such as preventative voiding. That means going to the bathroom all the time. Whenever you see the toilet, you're at the grocery store, you've got to run to the bathroom just in case. That's a sign of pelvic floor dysfunction. Or avoiding drinking any fluids because you're concerned you may have the urge to go to the bathroom. Some common bowel signs of pelvic floor dysfunction, of course, involuntary loss of gas or stools, but also fecal smearing. If you go number 2, you clean yourself really well, but when you go back later, you may notice some streaking in your underwear. That could be a sign of pelvic floor dysfunction. Although many physicians may define constipation as not going to the bathroom or going to the bathroom less frequently than every 3 days, I see clinically, and a lot of my colleagues in pelvic floor health will define a constipation as not going, going less frequently than once every day. That's where we start to see some of the pelvic floor disorder develop. If you're straining or pushing or bearing down to have bowel movements, or if you find yourself always having to push on your perineum, that's the area in women between your vagina and anus, or in men between the testicles and anus, that may be a sign of pelvic floor dysfunction, as well as for women placing a finger into the vagina to encourage stools to come out of the anus, or not being able to completely empty your bowels if it feels stuck, or if you feel yourself unable to cut off the stools, or if you find yourself constantly bloating or cyclically bloating, that could be a sign of visceral or pelvic floor dysfunction. So there's a lot of symptoms here, and a lot of these don't always occur to people that they may be connected to pelvic floor dysfunction. Prolapse, so that's the pelvic floor organ descent. Obviously, if you look in the mirror, if you look down and you see something there that was not there before, something that doesn't look like it belongs, that is a clear sign of prolapse. But in the more subtle side of things, we'll see people, or I will see my patients have a feeling of heaviness in the pelvic floor. And often that feeling will increase towards the end of the day when they're fatigued, or if they've been coughing or lifting a lot of heavy things. And finally, pain. This one would seem sort of self-explanatory. Pelvic pain obviously is a sign of possible pelvic floor dysfunction, but for a lot of people, it may manifest differently. So if you have pain or burning with urination, especially if you've had a UTI ruled out, that could be a sign of pelvic floor disorder. If you have severe menstrual or cyclical pain, that can be a sign of pelvic floor dysfunction, especially pelvic floor myofascial dysfunction. And then finally, if you have back, tailbone, hip pain, pain with sitting or standing, prolonged postures, or referred nerve pain like sciatica, that could be another sign of pelvic floor pain. As we're about to talk about, all these structures are pretty close to one another. They can refer to one another, and they can cause dysfunction in each other. So if you've had these kinds of pains that haven't responded well to pelvic floor physical therapy, to normal physical therapy or other treatments or self-treatment, it might be the time to start to think about what might be going on in your pelvic floor. So I'm just going to pause there for a second before we move on and see if there are any questions. We're doing good?
I don't see any questions yet, but it just, it's when you lay these out, it's just amazing to me how common so many of these symptoms are for so many people, and how I think even, physicians don't always think, oh, maybe this is something going on with the pelvic floor. And so I think it's something that can be so under-recognized and I think undiagnosed in a lot of patients.
Yeah. And, that actually leads me right into what I wanted to say next, which is the biggest question that I get from my patients. Am I normal? Right? We all want to know, is this normal? Especially from my moms. So they come in, they're like, did my baby break my vagina? I have actually had that asked. And I'm like, maybe. In all seriousness, I think it's a really hard question. And I always try to gently draw the divide between common and normal. I don't ever want my patients to be embarrassed about feeling this. There is no shame in having any of the symptoms that we just listed. They're a product of our life experiences. But there's a lot of limited information out there, and there's a lot of people who are uncomfortable or feel fearful about these symptoms. And then even when we do have the opportunity to connect with friends and family, we often see that they're experiencing the same things, but even that's a bit of a double-edged sword, because I think the normalization is a bit of an issue. So like you said, there are so many symptoms, so many signs that there might be an issue. And really what I want to bring to my patients, or to my friends and my family and my community, is that there are things we can do about it. You don't have to live with even the subtle symptoms of pelvic floor dysfunction. We can really make a difference in your life. So I know that that was an overwhelming list, and maybe even like a stress-inducing list of different symptoms. But really, I want you guys to come away with the thought that, hey, I know it's a problem, or it might be a problem. There's something I can do about it. Before we go on, I do want to discuss a little bit about the pelvic floor to give us some context about this structure, because no pun intended, it's kind of a black box. We're like, what is the pelvic floor? Where is the pelvic floor? What does it do? Why is it so important? And it is absolutely an essential set of muscles. We're going to talk briefly about the location of the pelvic floor. I am going to use some anatomical drawings, no real graphic drawings here today. But we're going to look first at this sort of system of layers of the pelvic floor. So you can see kind of in this upper left corner, we've got the more superficial layer, then to the side, a deeper layer, and then in the lower right corner, the deepest layer. So this layer, really 3-layered muscle system, creates almost a hammock, which provides support to the pelvic organs, as well as to the abdominal viscera, and kind of our GI tract that sits on top of the pelvic organs. You can also appreciate that there is sort of this system of loops. You can see these more circular looking muscles. And part of that is showing their role in reinforcing and providing support to the sphincters, right? So we have more support to the anal sphincter and to the urethral sphincter, so that it can help us in not involuntarily losing stools or urine. We also can see superficially there's some support to the vaginal opening. These muscles kind of act as like curtains to the vaginal opening. So you can see evidence of these 2 roles of the pelvic floor here, where it creates closure and also support for the organs, almost like a hammock for those organs. Another important component of pelvic floor function, and probably the least understood by people who aren't PTs, like who don't go to school to study this specifically, is its role as a component of the core. So in this picture here, we've got what we call the soda can model of the core. The way that the core creates stability in our body is by managing pressure. And so a lot of times we as PTs and some physicians will kind of model that as a soda can, with the diaphragm being the top of the soda can. the transversus abdominis, or the corset muscle, creating the sides of the soda can, and the pelvic floor following up as the bottom of the soda can. So just like in a can of soda where all of the metal pieces kind of face each other and contain the pressure, these muscles work together to contain the pressure in our abdomen. When we're laying flat, there's not really a lot of pressure in the abdomen, but as soon as we sit upright, right, our postural muscles get to work. These three muscles in this system really do a lot of work to help maintain the pressure and stability that is in our abdominal and pelvic cavity. It increases when we do things like cough, sneeze, stand up, lift, and carry. So the more we do these things, the more taxing it is to our pelvic floor. So if any of these components, our corset muscle, our diaphragm, or our pelvic floor, aren't working efficiently, whether that's because of injury, whether that's because of surgery or posture or different ways that we move our body, there's the possibility that our core isn't functioning as well as it could be. The other thing that I'd like to highlight quickly, especially as it relates to referred pain and that aspect of pelvic floor dysfunction, is the relationship of the hip and the pelvic floor. So a lot of our deeper hip muscles originate very close to the pelvic floor. The pelvic floor is actually not pictured in this illustration, but I do want you to appreciate how there are so many different hip muscles and nerves that are just adjacent to the pelvic floor. And this is more of a view from behind. So you can see how it's possible that muscles that are near the pelvic floor could not only refer to the pelvic floor and vice versa, but could also potentially cause tightness and dysfunction in the pelvic floor and vice versa. So it's all fun and it's complex. So for me as a practitioner, I love solving these problems, but it's a lot to think about as an individual, especially if you are suffering from pelvic floor dysfunction.
Stasi, can you take a minute and explain what referred means in saying that you could have a symptom referred?
Absolutely. So because of the way our nerves work in our body, sometimes when we have irritation in one area of our body, these signals can be perceived as coming from a different area in our body. So referred pain is basically pain that is caused by somewhere else in the system. It is causing the pain, but the pain is felt elsewhere. And so if you've had sciatic nerve pain, that's a prominent example. That's something that a lot of people are familiar with, pain that comes down the leg that's actually coming from somewhere else up in the system. Does that make sense? Is that
Yeah, and just give us some examples of what common things you might see with referred pain.
Oh yeah, absolutely. So my favorite one, so I did have a patient who came into me and she had pain, like kind of right under her belly button. And she felt this all the time, and especially with sex. And let me see if I wonder if I can actually scroll back to this picture. So her pain had actually originated, sorry, I'm going all the way back here. Her pain actually originated in the urethra vaginalis, which was just up underneath the urethra here. And that pain during intercourse from that tight muscle being kind of disturbed by the friction of intercourse was referring pain up to her belly button. So the source of the pain was absolutely not where her pain was being felt. So that was a really interesting one. There are pain maps from research that are very interesting, but our bodies are also different and unique. And even though we know, like, as doctors, as researchers, we know that there's a certain way that muscles do tend to refer. Every body is unique. So certainly I see pelvic pain being referred to the low back. into the hip, into the thigh, into the groin, but it can be referred up into the abdomen, and it can be referred up into the rib cage. So it really can spread pretty far. It's a little bit remarkable how far the pelvic floor can refer, but it is unique from person to person.
That's fascinating. I would never think if someone came in and was telling me about a pain below their belly button that it would be, pelvic floor would be like the first of like 10 things I would be worried about. And so, it's one of those, patterns that can be surprising. It can really take a long time. I'm thinking about all the testing I would do to rule out things in the abdominal organs before sending, the patient to actually get some relief from a pelvic floor physical therapist.
Yeah. And so that just points out, not every person has the good fortune to have an excellent and really interested and engaged primary care physician, unfortunately. So for a lot of women, and a lot of people, I should say, pelvic floor dysfunction, usually we see at least a delay of 6 months between referral and treatment. And for realistically, we're looking more at 5 to 7 years, especially when we're talking about pelvic pain. So that's where I kind of talk about, like, let's open the discussion. Let's have the discussion. Let's not normalize, even though it is stressful to acknowledge sometimes. The sooner we get people in that course of being assessed, the better. Okay, so we had an anatomy lesson, and now we understand the problem and a little bit about the structures. And so now I want to talk briefly about why. Why do we develop pelvic floor disorders? What puts us at risk? And especially what kind of things besides just our anatomy can put us at risk? So I always like to kind of open with looking at the differences between men and women. And across our lifetime, women are many, many times more likely to develop a pelvic floor disorder. And the primary reason for that, other than the fact that I like to say, our pelvic floor, it's got a hole in it, right? The levator hiatus, or the vagina, the vaginal opening, does place us at a structural disadvantage. There's just a little bit more structural integrity to the male pelvic floor because they don't have the levator hiatus. The other component is that people who are born biologically male will not experience childbirth. And so because of that, they will not be subject to the primary risk factor for the development of pelvic floor disorders. So even so among the rest of us, what is it that kind of makes us more likely to have pelvic floor disorders? And so there are several things from a systemic level that do predispose one to developing a pelvic floor disorder. And many of these are kind of connected to that pressure management and sort of the integrity of our connective tissues. That includes our skin and our muscles and our tendons and all of the things that provide support and help manage pressure. So research has found that if you have a BMI that is higher than 25, it's not a perfect measure by any means, but increased mass is associated with increased pressure and can pose a challenge for pressure management. Smoking is another factor that places you at risk for pelvic floor dysfunction because it really affects the collagen production and the elasticity of our tissues, and as well as our systemic health in general and our blood flow. A lack of exercise also affects blood flow strength. It increases the burden to our core, right? If we're not training the rest of our body, our core has a lot harder job to do in maintaining the stability and mobility of our body. Diabetes, especially uncontrolled diabetes, can also cause changes in our connective tissue and also leads to increased inflammation across the system. And constipation also increases pressure in our abdomen and the load that our pelvic floor has to bear. Non sort of physiological risk factors that have been receiving a little bit more attention lately include stress. from a clinical perspective, I certainly see this. My patients who had previously minor pelvic floor dysfunctions have seen, sometimes we'll see their symptoms just explode or multiply after a stressful time in their life. So I see that clinically, and now the research is really starting to back that up. And we also see that people who struggle from a socioeconomic perspective, or who haven't had the benefits of higher levels of education, also have a higher incidence of pelvic floor disorders. And a lot of that, according to research, is because they don't really necessarily have the same access to excellent healthcare as people who do have the benefits of higher levels of education or a better socioeconomic status. So these are things to consider, especially in today's climate. A lot of people are struggling, and so there is an increased incidence in pelvic floor dysfunction due to these non-physiological factors. So we talked about how moms are more likely to have pelvic floor dysfunction. And so why? What are the things beyond just giving birth to a child that cause pelvic floor dysfunction? Research shows that women who don't have children, they're still at an increased risk of developing pelvic floor dysfunction as compared to men, at about a 12% rate. But women who do have children are much, much more likely, about 3 times more likely to have a pelvic floor dysfunction. The more pregnancies a person experiences, the higher their level of risk. This comes from a very large study that looked at people who had the 3 most common types of pelvic floor dysfunction. And what I really like to look at is this last set of columns here, which is obviously the highest. And this is people who have more than one pelvic floor disorder. And so looking at women who haven't had any pregnancies, we can see that 12% figure, and how it just sort of incrementally increases until 3 or more. We're getting to that 34% of all women who've had 3 or more children are likely to have, are developing at least one pelvic floor disorder. So the more children you have, the more likely you are to have a pelvic floor disorder. There are some other birth-related factors. So it's becoming more and more common to see women having their first children after the age of 30, and there are lots of wonderful and healthy pregnancies after the age of 30. But unfortunately, because of tissue changes, it does place the woman at a higher risk of having pelvic floor dysfunction. Assisted birth, so having forceps or vacuum, the baby being born face up, also places the pelvic floor at risk, elevated risk for trauma. Increased pushing, again, strain on the pelvic floor for a longer period of time. Injury to the anal sphincter. It's not uncommon for a woman to have some tearing during childbirth, especially during obviously vaginal childbirth, but a stage 4 tear that extends to the anal sphincter is certainly correlated with much more severe pelvic floor dysfunction. And having a larger baby, which I'm seeing a lot of my patients with bigger babies these days. We have wonderful nutrition, lots of great healthcare, but unfortunately that does lead to a baby that's just a little bit bigger, especially if the pregnancy does progress past the due date. So I'm just going to pause there and make sure we don't have any questions.
I don't see any questions in the chat.
Awesome.
But if people think of them as they go, do drop them in there, and we'll get to them as we get to little breaks in the presentation. I think this is something that is so common and so universal, and especially in such vulnerable times of women's lives where they may have a new baby at home. They feel like they don't get time to shower, let alone to deal with the havoc that has just been wreaked upon their pelvic floor. And so I think it's something that, it just helps to people to understand that they're not alone, and that it doesn't mean they have to suffer in silence, and that it's really important to take care of moms as well as, the newborn babies that that have just very drastically changed their pelvic floor anatomy and function.
Yeah. And I think that like the stress actually kind of pushes us towards habits that maybe aren't the best for us. Like, not giving ourselves time to do our normal biological functions. I had a mom describe it as, she's like, I've got 3 kids under the age of 4. I've got a power poop. Like, I've got to go to the bathroom and get that stuff out. And I'm like, that's maybe not the best thing for your pelvic floor, but these are the realities, and it's really tough. And so I'm always encouraging everybody in my life, like, just reach out for that support, whatever you need, so that we can get you a little bit more aware of what your body needs to function well, especially under these times of tremendous challenge and stress. So we've talked about problems, we talked about risk, and let's talk a little bit about solutions, right? How can we make this better? And this is definitely more from a physical medicine, physical therapy perspective. But I really want to talk about posture and breathing. And this is one that's a little bit harder to manage on your own, because I do want to definitely highlight some steps that you can start to take today to make your function better. But I do want to talk about posture and breathing, because I think that this is one thing that many people aren't aware of. And it kind of it's building off of the concepts that we talked about with the relationship of the pelvic floor and the rest of the core. And the reason why so many women have pelvic floor dysfunctions that persist even after their pelvic floor is healed, or even if they're able to do Kegels, is because postural changes that happen during pregnancy and even outside of pregnancy can have such a strong effect on the way that we manage pressure in our trunk, that it can perpetuate these symptoms well after healing has taken place, right? So these changes in pregnancy do tend to be extension. That means sort of a backwards bending of the upper part of our trunk, as well as an anterior tilting or an increased arching in the lower part of the back. When we have that kind of a posture, it creates increased tightness in the front of the hips, as well as the low back. It also increases weakness and lengthening through the front part of the abdomen, where that corset muscle really needs to be doing its work. A lot of women will tip their trunk back because as the baby starts to grow, they've got to get that breath. They're trying to take a full breath, and the diaphragm doesn't have as much space to expand. So these postures don't necessarily resolve after childbirth. And there are a lot of other reasons that people will develop these postures, even if they haven't been pregnant or they haven't carried a child.
Yeah, I'm totally thinking about just how much low back pain and tight hips I see in my practice. And also personally, I remember one time my hip was really stuck several years ago, and I spoke with an expert about it, and he said, well, sometimes that's just because you're sitting too much. And it was just suddenly the very gentle comment of basically, you haven't exercised in 5 years. And we work too much. And I would say that 90% of the people in my practice sit too much, including myself. So just something so simple as that can really cause low back pain. And I'm curious, either now or later, maybe you could address for those people, whether pregnancy related or not, men get this, that what happens, how would you handle somebody's low back pain differently as a pelvic floor therapist than a traditional therapist?
So, I think of myself less as just a pelvic floor therapist, but more as like a whole body systemic therapist. So
Mhm.
the pelvic floor is a component of the core. And I see people, when I see people with a lot of back pain, that's probably the number one thing that I treat. It doesn't happen in isolation. A lot of
Yeah.
times my patients who have pelvic floor issues have back pain. And so that's why I absolutely have to address posture. And the reason for that is if somebody comes into me and they said, oh, I just bent over and I picked up a pen from the ground and then like my back went out. I'm always looking for the root cause. And usually the root cause in people who don't have a traumatic injury is what we call repetitive microtrauma. And that repetitive microtrauma is a fancy way of saying death by 1,000 cuts, right? It's the postures that we hold ourselves in every day. Like I said, you don't have to have carried a child to sort of have that extended and anterior pelvic tilt position. A lot of people in this area have it because it's more of a military posture, right? A lot of like type A, stand at attention, kind of like we're going to be erect and very present in this room. That's the posture that a lot of people can develop. And it's not just because of childbirth. So I like to address posture as a way for us to reduce strain in the muscles of the back and improve the ability of the muscles of the core to act and to create the stability that the back really does need. And so as a pelvic floor therapist, if the pelvic floor itself does need to be treated, I'm able to go in there. But I would say that there's an even 50-50 split between my patients who come in with pelvic floor issues as well as back and postural dysfunction. We can fix their posture and then their pelvic floor issue just goes away. Because it's not that their pelvic floor muscle is so weak, it's that their entire core cannot function because of the postural dysfunction that they've got going on.
Mhm.
So that's why I love to talk about this, because it's really something that most people don't think about. So like if your front of your hips are tight, if your low back is tight, if you find that your lower ribs are sticking out, if you can only breathe into your shoulders or in your low belly, right? If you have that little mom pooch, right? That just never goes away, as much as you try to suck in or grip your abs, right? If that's you, right? We've got to fix your posture. We've got to find a way to get your diaphragm stacking over that pelvic floor so that your core can function again. And that's one of the major ways that I treat pelvic floor dysfunction.
Yeah, that stacking over the pelvic floor, I think, is another cool visual about, at one point, you're talking about the soda can model, and at one point it was described to me as two bowls. Like there's a bowl on the bottom that's the bowl for the pelvic floor, and then there's the diaphragm, which is an inverse bowl, and they have to actually meet up. Like the rims of those bowls need to really face each other. And if you're not really holding your pelvis and your lower spine and your ribs and your shoulders, because they all attach in the right orientation, then neither set of muscles can function at their best, because they're already kind of pulled into a less functional position.
Right. And the picture in the middle here is exactly what you're talking about. The diaphragm and the pelvic floor are opposing one another, and they create this nice, evenly distributed pressure system. And so the back muscles don't have to overwork, the glutes don't have to grip, your six pack doesn't have to grip, right? All of these different muscles can be relaxed because your postural muscles, the core muscles, can just kind of hold you up there. But if we get into that backwards tipped position, your back muscles have to overwork to hold your trunk up. Your diaphragm and your pelvic floor can't oppose one another, so they are at a disadvantage mechanically. So
So we've
And-
got a couple of questions, some of which I may hold to the end, but one question is, what does good posture look like?
Okay, so I'm gonna pop right back to this here. So good posture is posture where the trunk, right? So the rib cage sits vertically over the pelvis. So in this middle illustration here, you can see that the diaphragm is sitting right over the pelvis, and the pelvis isn't tipped excessively forward, and it's not tipped excessively backwards. Basically, I like to say, if I can imagine my rib cage as a tube and my pelvis as a tube or a cylinder, I want those two cylinders to sit on top of one another without without the trunk or the rib cage being tipped backwards or forwards. We want them to sit stacked on one another so that Dr. Beauvais said those two bowls can face one another and maintain the pressure in our abdomen and our pelvic cavity efficiently for us. That's how we avoid that strain in our back or any other compensatory mechanisms in our body.
And another participant asked, are you going to show us exercises to improve posture?
So I mean, it's pretty unique, really, in terms of exercises. So a lot of the basic things that I give people are mobility exercises to open up the front of the hip, because a lot of times people are stuck in extension. So anything that stretches the front of the hip, our hip flexors would be a good exercise. Improving mobility of the low back, doing things like cat-cows or posterior pelvic tilts are good examples of exercises. I think that that's a little bit beyond the scope of my presentation today to show exercises to improve it, but there's a lot of general mobility work that can be done to improve this. And that actually brings me perfectly into my next topic, which is mobility and strength. So this is something that you can do, and if you're not quite at the point where you want to seek out pelvic floor therapy or just the help of a physical therapist in general, generally increasing your flexibility and muscle mobility is something that will help. So I like to encourage people, if their physician has said, you know, you're good to exercise, try something, start slow, try something like yoga. If we're improving the ability of our muscles to lengthen on the front, the sides, and the back of our body, then we are really promoting improved core and pelvic floor function. If we're building muscle strength and mass, then we're helping our core and our pelvic floor by making things easier to stabilize. If we improve endurance, we make ourselves less likely to have those prolapse symptoms at the end of the day, or to leak at the end of a long walk, right? Because our body requires endurance as a component of our sort of postural muscles and their ability to support our body. So really, we can look at this from a more general perspective. For specifics, right? It'd be good to be assessed by a pelvic floor therapist or by a therapist in general, but anything that you can do that makes your body more mobile and stronger is going to improve your pelvic floor function.
And someone had asked if posture affects incontinence, or is there another primary cause from pelvic floor problems?
Posture absolutely affects incontinence. So if we're not able to kind of maintain the pressure in our abdomen by having that good, efficient posture, if we are constantly deviating from an efficient posture, then it can increase the amount of pressure that we feel that our bladder is subject to, as well as the ability of the pelvic floor to really hold and create the closure at the sphincters, right? Because there are multiple functions of the pelvic floor. One is to provide the closure at the sphincters, and one is to generally provide pressure management as a component of the core. So deviating or having a posture that is habitually out of that neutral position can certainly increase your likelihood of incontinence.
Right. And another one just popped up, which is somewhat related, that she can understand the need to not lean back. But for some of us older women, we also don't want to get that old lady hunch where we tip forward. As a result, I spend my time leaning back to avoid that. How do you make balance against that? Any tips?
I know, isn't that annoying? It's like, you gotta be the Goldilocks. And so one of the things that I often tell my patients, and a cue that I like to give them, is I want you to feel like you've landed squarely in the middle of your feet. When we bend backwards, we often feel like our weight is in our heel, right? When we lean forward, we'll feel like our weight is forward in the front of our foot. But if you can find a position where your trunk is over your pelvis, you'll notice that the weight feels like it's coming right down into the arch of the foot. So it's evenly balanced between the heel and the forefoot. And so that to me is often a cue that in my own body, I have my trunk, my rib cage stacked over my pelvis. Some other indicators that might tell you if you're bending too far backwards is if your back just constantly feels tight, because to bend backwards, your back muscles will have to be working actively. So if your low back feels tight, if your mid back continues to feel tight, see if you can take a breath in and settle your trunk just a little bit more forward over your pelvis. That means that instead of tipping forward like that, you're lifting up and just bringing your trunk forward over your pelvis. It's a little bit of a subtle difference, but it's the difference between, let's say this is your trunk and this is your pelvis. It's the difference between being here, tipped forward, versus being just stacked over the pelvis, right? That's why I like to use the image of two cylinders. We're going to use my old coffee cup and my my soda water here. Two cylinders stacked on top of one another. Bending backwards would look like this, right? But what I want to do is bring the rib cage over the coffee cup or the pelvis versus allowing it to tip forward. So once I land in this position, right, I'm stacked and I should feel my weight translate evenly down into the arch of my foot.
So I sometimes see the exact opposite, which is people that work all day with their shoulders in an anterior position. And then they're mostly people that are my age and older and have been sitting in that position for more than 30 years. And so unconsciously, we think we're sitting upright, but in fact, our shoulders are so underdeveloped in the back that even though we sit upright, our shoulders are in an anterior dangling position. And if that's not causing our neck pain, it could be causing our hip dysfunction. It could be causing it to be harder for us to get out of a chair. And I think it's hard to teach that connection without a lot of visits, like to really explain that. So one thing is, could you talk about the opposite problem, which is those of us whose posture is more anterior shoulders, extended neck, and what that does for our pelvic floor and our butt. And then I have a different set of questions about leaking, urinary leakage.
So actually that posture that you describe, it's not necessarily unlike, so most of the people that I see that do have rounded shoulders, they are arching back to try to get themselves into a more erect position. But you absolutely hit the nail on the head. While they're trying to compensate for their shoulder position with their back, the real problem lies, or part of the problem lies, in their ability to get the shoulders onto the back of the rib cage, right? That's where our shoulders need to be in order for us to have optimal upper body stability and mobility. So I absolutely, because I do treat holistically, a lot of times when I'm treating somebody with back pain who tells me, 3 sessions in, yeah, I've got a shoulder issue. I'm always here. I'm stuck. A lot of times we've got to get their shoulders onto the back of their rib cage and out of that forward rolled position in order for them to be able to maintain this neutral position, right? Because if we don't get their shoulders back, when we do stack up their posture and get them into a good position, they feel like they're here. So you're totally right. We do have to address this. We've got to address the whole system. Otherwise, the problem is going to be harder to kind of defeat. Does that make sense?
Yeah, I just think it's so vital, and it's so critical how interconnected all of these parts of our body are. And so, how do your shoulders sit really changes how you pee. I mean, it's true.
It's actually, like, I always joke with my patients, because my specialty is really in kind of tying the whole system together and providing this clear picture about how everything is interrelated. And I tell them, it's annoying, isn't it? Like,
Yeah.
I want to be like Mr. Potato Head and be like, oh, I got an arm problem. Let's just take the arm out and put a new arm in, right? Wouldn't that be great? But we've got to treat the whole system and really be patient with ourselves too. Not lots of young people have these issues too, but if we've had pain and dysfunction for so many years, being patient and understanding that our whole system may be involved in this, complex layer of compensations, we've got to be patient as we sort of peel the onion. And so finding somebody you can work with is great. Finding somebody who has that approach is fantastic. And that's why I opened my clinic. But it is complex, and I empathize with my patients as somebody who has many dysfunctions herself.
Could you also talk about the kind of neuropsychiatric part of that nerve signaling that makes people want to kind of constantly pee beforehand? And one of my patients who recently saw an excellent pelvic floor therapist came in and said, I just didn't realize that so much of my problem was behavioral. And so by reteaching some behaviors, she was able to really learn that her function was better than she thought it was. So this is a problem I see at least several times a week, about people who have to go to the bathroom all the time, and they can get untrained from that. So could you tell us a little bit about that connection and how to change it?
Yeah, absolutely. So there is like a true, neurological reflex arc that we have. Our bladders are actually signaled to go to the bathroom when they're about 40% full, but it is possible for us to uptrain our bladder. So in people who are going to the bathroom every, 10 or 15 minutes, I like to say, unless there are some people who really drink tons and tons of water. And so for those people, sometimes we have to talk about how much water do you actually need to drink. But for people who have upregulated their reflex to go to the bathroom, there is really a need to take a step back and see what a lot of the triggers are. And a lot of times I find that stress is playing a part here. So stress can increase our sympathetic activity. That's a part of the nervous system in our body that increases tone, right? And kind of helps release these cortisol and other hormones that basically make us higher tone, a little bit more tense. And that can increase the tension in the muscle that is on the front of the bladder that kind of contracts and gives us that feeling that I've got to pee right now. It can also increase the general tone of our pelvic floor. So besides, that uptraining, that feeling of I've got to go to the bathroom, I'm nervous about it, I'm worried that I might leak, that creates a stress response in the body, which only further promotes tension, which makes us feel like we have to go pee more. So a lot of the training that I do with people, beyond saying like, just don't go pee as often, you just don't need to, because that's actually not the kindest way to treat someone. Just saying like, oh, it's all in your head, you don't really have to pee. That doesn't always fix it. really what I like to do for people who have that kind of an issue is educate them, let them know, you know, what's afoot, that this is partly because maybe they've upregulated their system a little bit. They've trained their bladder to go earlier. You know, we obviously evaluate if there is any strength deficit, and if there is no strength deficit, then we start with what we call down training, which is just teaching the pelvic floor how to relax. And in a lot of people who do have this more behavioral urge to go to the bathroom more often, we teach them techniques of like using the relationship between the diaphragm and the pelvic floor and diaphragmatic breathing, and improved postural positioning in order to reduce the tension that they feel on the pelvic floor. So that's kind of a two-pronged approach, by educating them and letting them realize that their stress levels and their own uptraining of their bladder reflex and response can be offset. And we can also do these physical things like breathing and trying to learn how to connect to the pelvic floor and release the pelvic floor, so we don't feel like we need to constantly go.
Yeah, and you mentioned something about basically relaxing the pelvic floor. And I know I've spoken with several patients who were surprised to realize that in fact, they're trying to do Kegels all the time, but their actual problem was too much tone in their pelvic floor, and that learning how to stretch and relax those muscles was the key to their success, which was the opposite of what they were anticipating.
Yeah. I mean, I see that a lot of times, especially, gosh, even in women who are postpartum, and a lot of people who have prolapse. To me, prolapse is the most interesting, because the traditional model of treating prolapse was as a weakness, right? The pelvic floor is weak, and so this organ is starting to descend. But the reality is, a lot of times the women who I see who have prolapse actually have very tight pelvic floor. And they may have had other surgeries to try to address this kind of laxity, but really there's a lot of tension in the connective tissues in their pelvic fascia, right? So we go in and we do a lot of mobilization, and by mobilizing and improving the ability of the pelvic floor to relax, we improve incontinence, we reverse prolapse, we improve the ability for the pelvic floor to turn on when it needs to, and to really provide that core support. So it's really one of the areas that, you know, I like to encourage people to get evaluated if they have an issue, because a lot of times it's just Kegels won't do it.
Yeah, absolutely. It's so life-giving. And so many people haven't even told their doctor they have these symptoms because they're uncomfortable about talking about it, or because we don't ask the right questions. One or the other.
Or people may think it's just part of the, you know, aging process. Well, everybody
Right.
leaks after they get to a certain age.
Right.
And that doesn't have to be the case. It really doesn't. So that's why I'm all against normalization, right? Don't feel embarrassed, but like, let's not suffer. Let's not live with this.
There are a couple of questions, and I don't know if you'll be able to field them. So one attendee wonders, how much water should we drink each day?
Oh, I love this question. Okay. So there's the general recommendation for 6 to 8 glasses, you know, 6 to 8 ounce glasses of water. But depending upon your diet, you may need to consume more, and depending on what you're going through. Like a lot of the people that I see, they may be breastfeeding. So if you have a particular need that increases your hydration needs, then you will have to drink more. But if you eat like a lot of fresh fruits, a lot of fresh vegetables, and fresh meats, that provides a lot of liquid. So I like to tell people, you know, do you ever feel thirsty, right? Do you feel like your skin is hydrated? Do you feel like you're eating a lot of fresh foods? And if the answer is, you know, I'm not usually thirsty, I eat a lot of fresh foods, a lot of whole foods, then, you know, probably you don't have to stress about getting those 8 glasses of water in. But kind of like eating, you know, you got to drink if you're thirsty. usually I say if we can get a liter of water in a day, that's a good goal to hit. That's probably all the hydration you need. But if your diet is really heavy in processed foods, or if you have a medical condition, or if you're taking medications that make you have to go to the bathroom a lot, you probably are going to need to drink a little bit more water.
And there's another attendee who mentioned that her doctor prescribed estradiol vaginal inserts for urine leakage and urgency, and it's helped, but she's concerned about the long-term effects of using them and wondered your opinion of those.
So I love topical estrogen, and suppositories are one way that we can deliver estrogen to the vaginal tissues. And I think that they can be really helpful, especially if there's like a frequent UTI or a pelvic pain component. It helps increase the lubrication of the tissues, and it helps the local blood flow. So in that way, it can assist in continence as well. Previously, the biggest concern, and I'm sure that you, Dr. Beauvais and Dr. Cilenti, can opine on this, but from what I've seen from gynecologists, especially more old school gynecologists, the concern was for people who were who had previously had estrogen mediated cancers of the cervix and the uterus. There was a concern of the possibility to develop cancers because of the estrogen. But more recent research in the last decade has actually shown that even for people who have estrogen mediated cancers of the uterus and cervix, the risk is very, 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 very low. So if you are one of those people, that might be one of the things that you might want to discuss with your physician as to whether or not you should be taking that on a long-term basis. But by and large, it's really safe. It's a really safe medication that can have a massive impact on your urinary and also reproductive function, right? Lots of people, as they get older, find it really hard to have good sex and non-painful sex. And that's just a lifesaver for a lot of women. So I love topical estrogen. I think it's really good for women.
Yeah, I think it's something we use, I would say we use frequently, and sometimes people will be concerned about, breast cancer risks, but the systemic absorption is so low, and the, the benefit and quality of life improvement that people have is usually quite good. And so I think it's something that there's more and more of a trend to say that we shouldn't withhold these from women who really need it to help manage their symptoms.
Yeah.
Well, thank you so much, Dr. Palaia, Dr. Palaia and Dr. Cilenti for hosting. I think this was fascinating. I'd be happy to talk to you for hours about all sorts of specific aspects of the pelvic floor function. And we really, really tremendously appreciate the huge influx of pelvic floor experts, I would say, in the last 10 years, because in the first 10 years of my medical practice, that was not at all a common, and